So hello everyone, welcome to my new video. So today in this video I will discuss about diabetic retinopathy. So previously I discussed about hypertensive retinopathy in one of the last videos where I discussed how elevation of blood pressure lead to damage to your retina. So today I will discuss on how elevation of the sugar level or glucose level, there is hyperglycemia, lead to damage to your retina. Okay, so high glucose level in your bloodstream is known as diabetes. So etiologically this diabetes is two type 1 and type 2, where in type 1 diabetes mellitus what happened that there is damage to the beta cells of islets of Langerhans that lead to less production of insulin, so glucose not getting out from the bloodstream to the cell in the absence of insulin, so that's why glucose remain in the bloodstream and that lead to diabetes. Okay, that's one thing. And another type 2, here cell become resistant to insulin, so even after there is good amount of production of insulin, cell is not getting opening of that receptor to bind insulin, and that will allow glucose to get enter, so that's why glucose remain in the bloodstream and that lead to elevation of glucose level. So this lead to diabetes mellitus, and long duration of this diabetes mellitus can lead to damage to the retinal vessels, that is known as diabetic retinopathy. So normally these diabetes mellitus lead to damage in two ways: microangiopathy and macroangiopathy, right? So in microangiopathy it lead to a damage to the smaller blood vessel that include retinopathy, neuropathy and nephropathy. So nephropathy means damage to the nephron, that means kidney damage, right? So I will discuss with you all about retinopathy. Okay, so here what I mentioned, diabetic retinopathy is the complication that affect the eye and its vessel. So it is one of the leading cause of blindness in elderly people in Western countries. So if I tell you the prevalence of this diabetic retinopathy in our country, it's 12.5% among diabetic mellitus patient. Okay, now initially affected people are very much unaware of this condition till they go through a dilated eye examination. So that's why routine eye examination is very much important, and if you are having diabetes mellitus, then you should have yearly or every 6 months you should have a dilated fundus examination to rule out any risk of diabetic retinopathy. Okay, so let's discuss about some of the risk factors who are more prone to have this diabetic retinopathy. So first of all, first and foremost, if someone is having very much long duration of diabetes mellitus, so those people are more prone to have diabetic retinopathy. Second, if the person is having type 2 diabetes mellitus, then it is seen that type 2 diabetes mellitus are more prone to have diabetic retinopathy. Obesity like hyperlipidemia can also lead to diabetic retinopathy. And smoking, if someone is having lots of smoking tendency, he smoke very much, so that also can lead to diabetic retinopathy. Hyperglycemia, there is a higher level of glucose level in the body, as well as any kind of inflammation going on in the body, that can also lead to diabetic retinopathy. Okay, and another is like in many research article it is seen that females are more prone to have diabetes than males. Okay, so here in this picture you can see this is the normal fundus. So there is a way to read the fundus. Okay, so first of all, in a fundus photo you should see the optic disc photo. Okay, first of all you need to see the disc, then vessels, then macular area, then periphery. So if I see in this picture, optic disc is very much healthy and normal, vessels are also very much normal, in the macula it is also very much normal, and periphery there is nothing abnormality seen. But in this picture if you see, optic disc is very much normal and vessels are normal, but in this type of area you can see the microaneurysm. So what is microaneurysm? There is a secular outpouching of the blood vessels. Okay, so that I will come in the pathophysiology part. So here in the macular area you can see deposition of hard exudate. This is cotoneal smudge, dot and blot hemorrhages in all quadrants are there. So this is the case of moderate to severe non-proliferative diabetic retinopathy. So this is how you need to read the what to say fundus photo. So here if I tell some more about this fundus photo, this is a superior nasal quadrant, this is superior temporal, this is inferior nasal quadrant, this is inferior what to say temporal quadrant. So this is also NPDR as well as DME, you can see, because what is DME? There is a deposition of hard exudate within 500 micrometer area from the center of the macula. So here you can see deposition of hard exudate that is leading to the DME, that is diabetic macular edema. So that is how you will read this fundus photo. So from diabetes it lead to retinopathy, there is damage to the retina. So this is the pathophysiology of this diabetes. So here diabetes that lead to hyperglycemia, there is elevation of glucose, and that lead to AG. It should be AG, not ACE. Okay, AG, that is advanced glycation in product. So what is this advanced glycation in product? So these are harmful component when protein or lipid get combined with sugar molecule, it lead to formation of AGE, that is advanced glycation in product. So the process is known as glycation. Okay, so this AGE is mostly found in food grilling, frying, toasting, and if you eat such food very much, then it will lead to accumulation of AGE in your body. The good thing is our body can remove this AGE very nicely, but if you live a very unhealthy lifestyle and maintaining you are metabolically not that much stable, so it will lead to more accumulation of AGE, and that lead to oxidative stress. Now suppose someone is having diabetes. So diabetes, he is having diabetes, that means there is a higher level of glucose level in the bloodstream, right? So there will be more protein and lipid combined with that glucose molecule, and it will lead to more accumulation of AGE into the body in diabetic patients. So that's why diabetic patients are more prone to have this AGE accumulation that lead to oxidative stress. So because of this oxidative stress that is leading because of this AGE accumulation, it lead to three conditions. First of all, let's come to the thickening of the basement membrane. So because of this oxidative stress, it lead to edema formation, and that lead to thickening of the basement membrane. So because if the basement membrane is getting thickened, it will lead to hypoxic condition to the retina, and it lead to activation of vascular endothelium growth factor. Okay, so once this vascular endothelium growth factor happen, then it will lead to neovascularization, and ultimately it will lead to PDR, that is proliferative diabetic retinopathy. So I will again repeat that hypoxic condition. So this hypoxic condition lead to more production of proangiogenic factor that will lead to activation of vascular endothelium growth factor, because hypoxia means there is less production of oxygen. So to produce or to supply oxygen to that hypoxic area, our retina will try to make new vessels that will produce or supply blood vessel to that non-perfused area to supply oxygen. Okay, that will, and but the newly formed blood vessels are not that much well formed, and they get busted, they get ruptured. So this formation of new vascularization, once you see in the fundus, it will definitely indicate that the patient is having proliferative diabetic retinopathy. Now let's come to the pericyte cell damage. So here in the blood vessel wall, the component is what to say endothelium, pericyte, and astrocyte. So pericyte cells are very much important to maintain the normal blood vessel integrity. So if there is because of the oxidative stress, if pericyte cell damage start, it will lead to endothelium cell damage also, and because of this thing, it will lead to breakdown of blood retinal barrier. So as the blood retinal barrier is broken, it will lead to hyperpermeability. So because of that, there will be more accumulation of hard exudate in the retina, as well as edema formation chances will be more. So that's why, because of the hyperpermeability, blood plasma can get clot beneath the retina, and if it is nearby to the macula also, it lead to diabetic macular edema. So these two conditions affect vision. Now let's come to the mitochondrial dysfunction. So here you can see ROS. What is ROS? That is reactive oxygen species. So reactive oxygen species are oxygen containing molecule that have capacity for independent existence, like hydrogen peroxide, superoxide anion, such things. So these normally reactive oxygen species help in fighting with microorganism and such thing. But if there is high production of this reactive oxygen species, it also can lead to oxidative damage or also vascular damage. So this thing can lead to hyperpermeability, and ultimately this thing lead to diabetic macular edema. So this is what happening in the diabetic retinopathy pathophysiology. Now once and pericyte cell damage, it will also lead to one specific finding that is known as venous looping or venous beading. So why venous looping? That means the blood vessel will appear in a looping manner. Why? Because the cellular integrity is lost in that vessel. So that's why it is distorted now. Okay. So these are the types of diabetic retinopathy. So here you can see that diabetic retinopathy is three type: non-proliferative, proliferative and maculopathy. So proliferative diabetic retinopathy is the severe stage, then NPDR. But maculopathy or diabetic macular edema can happen in any stage, not NPDR or PDR, in any stage. There is no rule that DME will happen only in PDR, not in NPDR. It can happen in any stage. Okay. So here this is the montage mode fundus photo picture, where you can see all the quadrant having dot and blot hemorrhages with hard exudates you can see, and you can also see the coronal spots are also there. So that is indicating a very severe non-proliferative diabetic retinopathy stage in this thing. Where also you can see there is hard exudate deposition in the macular area also. So this is a case of DME as well as severe NPDR. Okay. Now here NPDR is divided into what to say four type. That is mild, moderate, severe, and very severe. So how you will tell which fundus photo is having which stage? So there is a way to understand which stage is having. So mild, moderate, severe, very severe. So in this case you can see optic disc is normal, but here in the superior nasal quadrant and inferior nasal quadrant you can see dot blood hemorrhages as well as hard exudates are also there, and you can see there is a circular appearance of the hard exudate, that is known as succinate retinopathy. Okay, so you can see this finding also, as well as the hard exudates are also in macular area, that is indicating DME. So it is a case of moderate NPDR with diabetic macular edema. Okay, and here this is a case of severe NPDR, where you can see in this quadrant dot blot hemorrhages with hard exudates formation you can see here. And so it is the case of moderate NPDR. Okay, non-proliferative diabetic retinopathy. Now how you will differentiate different stages, that which fundus is in which stage? So that is what I am going to discuss now. So let's talk about moderate NPDR. So in moderate NPDR, so sorry, let's start from mild, right? Sorry, mild NPDR. So here you will only see microaneurysm with venous looping. Okay, so here where is the picture? Here you can see that venous beading and venous looping. So looping will be like blood vessel is coming, and it is in a looping manner, like in this way. Okay, in a looping manner. So this is venous beading or venous looping. So in mild cases you will see microaneurysm with venous looping in one quadrant or all quadrant, but you will only see microaneurysm and venous looping, that is very much normal. So what is microaneurysm? There is the secular outpouching of the vessel. So here you can see in this picture, you can see that this is microaneurysm. Here blood vessel is not brusted, but it is leading to going to be burst. So when this microaneurysm forms, so in the pathophysiology part where I told you about the endothelium cell damage, and because of the endothelium cell damage, So the blood vessel wall is getting thinner, so that's why it is getting swell up, and that lead to formation of this outpouching area, that is microaneurysm. So once it get brusted, it will lead to formation of hemorrhages. So there is two kind of hemorrhage you will see, so dot and blot hemorrhage and flame shaped hemorrhage. So this dot and blot hemorrhage you will see in outer plexiform layer area, and flame shaped hemorrhage you will see in nerve fiber layer. Okay, so in mild NPDR case, you will only see microaneurysm with venous looping or venous bleeding. Now in moderate NPDR, you will see additional symptoms with symptoms of mild NPDR. That means you will see venous looping as well as microaneurysm, as well as you will also see retinal hemorrhages. Right here microaneurysm will get brusted, and hard exudate, coronal spots, venous bleeding, all such finding you will see in moderate NPDR in one or all quadrant. Okay, and in severe NPDR, so you will follow severe NPDR case 4 to 1 rule. So in you will see hemorrhages in 4 quadrant, as well as you will see venous bleeding in 2 quadrant or more than 2 quadrant. On also you will see IRMA. What is IRMA? That is intraretinal microvascular anomaly. So when it is formed, when there is non-perfusion area is there to supply blood or oxygen to that non-perfusion area, there is a bunch of vessel start growing in the retina itself. It is not neovascularization, it is in itself in the retina a bunch of blood vessels start growing to supply oxygen to that non-perfusion area. There is IRMA. So people get confused between IRMA and neovascularization. So in IRMA, you will see only blood vessel is growing in the retinal area, but new vessels can go to anywhere. It can go to vitreous, it can go to ciliary body, iris, or angles also that lead to secondary open angle glaucoma, such things. But IRMA will not, it is not that much harmful if I compare with neovascularization. So, how you will differentiate a case of IRMA and neovascularization? By doing fundus fluorescein angiography. Okay, so that is how you will differentiate. You need to follow the 4 to 1 rule also. So here if I tell about the PDR, once you will start, once there is starting of new vascularization, it is known as PDR. So NVE and NVD, there is two things. NV means the new vascular vessel is in retina, or it is in from retina to vitreous, from retina to ciliary body, iris, anywhere, and NVD means new vessels start growing in the disc itself. So there is some blood vessel, if it start growing over the vitreous area also, and it will get burst, it will lead to formation of hemorrhages. Okay, so that is PDR. Now here in this fundus you can see everything within normal limit, but in this picture you can see there is a microaneurysm is there. So this microaneurysm is very much nicely seen in fundus fluorescein angiography, but here it's quite difficult to understand this thing properly. Now in moderate cases you will see coronal spots, hard exudates, right, with microaneurysm formation, that is moderate. In severe, here you can see uh, severe exudate, macular bleeding, or dot and blot hemorrhage in all quadrant. Also you can see the tortuous vessels also here, and here hemorrhages, DME. It is severe case of NPDR, and once you will see there is formation of new vessels, and it will get rupture, so it will lead to pre-retinal hemorrhages. So this is the case of PDI, that is proliferative diabetic retinopathy. So this is a venous bleeding, and this is a IRMA. IRMA, you can see that there is a bunch of vessels are there. So there is a IRMA. Okay. So here in this picture you can see deposition of this hard exudate in the macular area. So that is clinically significant macular edema. Okay. But you will not see any new vessel anywhere. Okay. So in this picture you can see there is vitreous hemorrhage. Because of the vitreous hemorrhage, the fundus is very much hazy manner, and you can also see the periretinal hemorrhages. Hard exudate is also there. So there is a case of proliferative diabetic retinopathy case. So here in NPDR, don't get confused about this membrane. It is an ERM formation. So here in this picture, in all quadrant, you can see dot and blot hemorrhages with microaneurysm formation, coronal spots with hard exudate, and clinically significant macular edema. So that is the case of severe non-proliferative diabetic retinopathy. So if I tell about this OCT finding, so it is a case of DME. So here you can see the normal VR interface foveal contour is really much elevated, but the inner retina showing cystoid macular edema, and also there is a outer serous retina showing NSD, there is neurosensory detachment, but RPCC complex is very much normal. So there is a case of diabetic macular edema. Okay, so here there is a cover up or eye of every finding. So here you can see hemorrhages, blood vessel, microaneurysm, hard exudate, optic disc, macula. Here you can see deposition of hard exudate and coronal spots. So how you will differentiate a hard exudate from coronal spots? First of all, if you see in this picture, hard exudate are very much bunch manner. There is lots of hard exudate, but there is a very much isolated. Coronal spots are always isolated manner. Okay, so there is one differentiation. Another thing, if you see only hard exudate, there is no that much risk factor is there. But if you see coronal spots, there is indicating ischemic condition going on in the retina that is leading to blockage to the exoplasmic flow. So that's why it is quite risky factor. So you need to concern about this thing and take some precautionary actions. So always, if you see that any patient is having this kind of appearance in the fundus, then tell the patient to go for a systemic evaluation, or if they are already diagnosed diabetes, then tell them to control the sugar level properly, otherwise their vision will definitely getting affected in the coming future. Okay, so that's all friends, thanks for watching. Please don't forget to like my subscribe to my channel. I hope this video helped you a lot in understanding about diabetic retinopathy properly. Thank you so much.